Hello, everyone. This is Anna Maria Turano, Vice President of Marketing at Cincy. Welcome to today's webinar, which will highlight how HHQI, the Home Health Quality Improvement National Campaign, can help home health organizations such as yours make a difference in patients' healthcare and ultimately their quality of life. Today's webinar is hosted by Cincy. Cincy is a technology company with an award-winning virtual care platform that enables home health agencies to better engage patients and colleagues while optimizing available staffing resources via HIPAA-compliant video, email, and secure messaging. Today, I'm delighted to introduce Cindy Sun, who is our guest presenter. Cindy is the lead project coordinator for Quality Insights, the Quality Innovation Network, and the Quality Improvement Organization. Her primary responsibilities are with CMS's HHQI national campaign and include assisting the nation's home health agencies with analyzing and integrating data into their quality initiatives and leading over 150 network coordinators through cross-setting collaboration. All of this is with the one goal of supporting home health agencies through quality improvement changes. All webinar attendees are muted during today's presentation. If you have a question during Cindy's presentation, please type your question into the chat window on your control panel. At the conclusion of today's webinar, we will review the questions and answer them accordingly or follow up with you individually. And yes, the webinar is being recorded, and we will make this available to all after the webinar concludes. Cindy?
Hello, and thank you all, everybody, for showing up, taking the time out of your day, and we want to be respectful for that. So I'm going to go over HHQI, and thank you for this great opportunity. I think that some of you may know HHQI almost as good or better than I do, but then others may have never heard of it at all. So having the opportunity to share with you what is going on and what is available to all home health agencies is something we're excited to do. Now, a little bit about HHQI for those of you that aren't familiar with it. We were given this goal statement by CMS to improve the quality of care that home health patients receive. Go. We were very fortunate. We've been doing this now for over 10 years, and our focus is on the reduction of avoidable hospitalizations by improving oral med management and improving falls and multiple disease processes. But the reason this is important to understand that this project is funded by CMS, Centers for Medicare and Medicaid Services, is for a couple of reasons. One, everything I'm going to talk about today, because it is funded by CMS, is in the public domain. That means there is zero obligation, there is zero fees. You can't pay for anything. It's all 100% covered by CMS. The other thing is over 1,000 resources that are evidence-based resources are available on HHQI, and all but maybe 5 to 10 of them are copyright-free. This means if you find a tool that you want to use, it has another agency's logo on it, you can remove that logo and put your own. Or if the text, our patient population would like a little different, we need a little different language, edit it. The 5 to 10 that do say copyright, you're free to use those in any way that you want, but you can't edit them, and mainly because they're validated tools. If you edit the text, you've lost the validity. So that's the reason it's important to understand that moving forward into this. Currently, we're working with over 23,000 participants, so as I said, some of you may already be participating in HHQI. This is the focus of where we are right now, like I said, focusing on the avoidable hospitalizations, reduction of that, improve oral med management, looking at immunization rates and immunization process that we have in all of our agencies. It's very different, as we know, because that is the reason it was removed, one of the reasons it was removed from the star rating, but it doesn't reduce the importance. So there's a lot of information and a lot of different tools and resources that you can use at your agency with different clinicians and different patient populations for that. We also focus on the improvement of cardiovascular health because that is still that is the #1 killer in our country. And we also focus on the underserved population because those of us in home health, I think, have more access and availability to this population than most. Our underserved population consists of patients who are dual eligible for both Medicare and Medicaid, populations that have disparities in care, as well as those who are small home health agencies, because we all know that those who are small home health agencies have a tremendous difference than those who are larger agencies. Home health is the focus of HHQI, but these tools and resources have been used in multiple care settings. So as we're talking about this and you're thinking about these different tools, think about the collaborative community partners that you are working with. Or maybe you are already with one of those other settings. Taking the HHQI tool, and sometimes they may need a minor tweak, but do that, and then the patients receive the same tools, and that's what we want to encourage you to do. Now at HHQI, we focus on 4 different categories: EDNA, education, data, networking, and assistance. And so I thought I would take today just to go through the highlights of each of those, just to make sure that you're at least aware of it. Because I got to tell you, when we do presentations in person, it's one of my most heartbreaking moments when an agency comes up to us and says that they've spent all these resources of time, effort, energy, and created this phenomenal tool. And granted, it's phenomenal, but yet we have 6 versions of it on HHQI. They could have used their time and their energy doing something else. And so my main goal today and every day is really just letting the agency website at the bottom, which is homehealthquality.org. On the right-hand side, you'll see the link that says registration, and then you'll see the word that says login. This will get you into all of those tools that I was telling you about. This is the main general access. I will also tell you now, and you can just go ahead and click off and say you don't want to deal with it, but there's also a total of 3 different registration systems on HHQI, and that's due to the level of security. So this is the one that is open to patients, it's open to families, it's open to every single person actually in the entire world. So and there is a keep me logged in feature on this one, because it does not give you access to anything secured. It is only all of the resources. Now, as I mentioned, it's funded by CMS. This means that you are not under any obligation when you log into this. The only reason we have this login is just for data tracking, so that we can report back to CMS that not what you're downloading, but what hospitals are downloading, what home health agencies are downloading, what physicians' offices are downloading. Also, we can say that these are human downloads versus a computer-generated. That is the only reason for this. The next thing we're going to do is just talk about education. Now, back on the main website, you'll find everything we're going to talk about under resources at this point. Under the resource tab is where you're going to find the best practice intervention packages. I'm an old home healther. We all are that work here at HHQI. And when we were in the agency, we did not have the time to stay current. And we knew we wanted to. We needed to, as all clinicians do. But we just didn't have the time. There was not 28 hours in the day. So when CMS gave us this project, this was brilliant because we were able to take all of the evidence that is out there and bring it down into one package. So through this best practice intervention packages of different topics, this particular one is fundamentals of reducing hospitalization, but there's quite a few others, probably about 25 others. We're able to take the evidence, put it into paragraph form. You can read a little snippet about it, and it links to the actual evidence so that you can go and find if you want to learn more about that specific one. There are clinician and patient tools alike, educational materials, as I said, the zone or stoplight tools, which I'm sure many of you are using. You want to make sure that those are current. These are available. They're updated on an annual to biannual basis, depending on what the evidence is supporting and suggesting. So even if you have the most phenomenal zone tool, you can have a look at the ones on here and make sure that your evidence is and your tool is current. Some of the BPIPs are in video format, multiple different media ways. As far as the videos go, all of the videos on HHQI can either be viewed, streamed live off of YouTube. There's also MP4 file formats that you can download and put on the actual tablets of your clinicians if necessary, or if it's something you want to do. There's also specific discipline sections, including home health aides as well as leadership. These are just a few of the topics that I mentioned about the BPIPs. So these are the in-depth best practice intervention packages. And you can read here, you can see the different disease managements, including cardiovascular health, falls prevention, that's our most recent one, wound management, underserved populations. So you can choose which topic and content area is most important to your particular patient setting and what the data is telling you that you're focusing on. Telehealth Disease Management Series these are tools that were initially developed 10 plus years ago, and they're currently undergoing a revamping. Some of them are already posted. The others are in the final stages of approval and will be posted by the end of May. So depending on the topic that you're interested in, this particular one is looking at COPD, but there's multiple disease management areas. And these are packets, they're toolkits, and they contain not only the clinician education tools, because we all, as clinicians, again, this is an area where we need to stay on top of the evidence, but yet don't have the time in a lot of situations to do that. They all contain patient self-care workbooks. Workbooks are fantastic for patient self-management and for helping the patient transition from one care setting to the other. Patient selection criteria. Which patients do we put on telehealth? We would love to put every patient on telehealth, but that's not always realistic. As well as the encounter and documentation tools are in each of these toolkits, and the decision support tools. Now, the resource library is where you will find all of these tools and resources that I was just mentioning. And this is where I was saying that you can get into as well as your patients and families. It's open to everyone. Customize, customize, customize as you see fit. Or you can just download. They're turnkey. They're ready to go right now. But if you would like to, you can edit them as you see best. So we're just going to go through a couple of the filters. Now, this is the first login that we were talking about that is required for here. Now, looking at the resource library itself, down at the bottom, in the upper right-hand corner, you'll see the icons. These icons do actually come in handy. I have been using this library. It's been around now for 4 years, and I will tell you the first 3 to 4 times I found it challenging. That's why I wanted to take the time today to just mention how to do this, because I've slowly figured out an easier way to do it. So down at the bottom of your page, you're always going to have filters. Use these filters. If it's a BPIP itself that you're looking for, choose the BPIP topic. If not, leave that blank. You'll have a topic area that probably has, I've not counted, 50 different topics you can choose from. Material type, you're going to have BPIPs, you're going to have interactive tools, you're going to have videos, you're going to have informative tools. Select your audience. Audience drop-down is going to include patients, it's going to include clinicians, therapists, leaders, home health aides, and of course select your language. Many of the tools have been translated into 5 or more languages. Personally, I always choose English so I can narrow my selection down once I've read it and decided what tool I want to use. Then I can go back and find what languages it's been translated into. This is just, I wanted to write it out in case you were printing your slides, that you would have the way to go about and to really look at which tools you want to use. Now, one thing under material type that I personally found challenging, and I don't know if you will or not, but information versus interactive tool. Informational resources are going to be those that are just narrative. Interactive tool is something that you're going to input information, such as a zone tool. You're going to put those vital sign parameters. You're going to put when to call the doctor. So if you're looking for something, Call Me First poster. Many of you are probably already using the Call Me First posters. There are multiple versions. That would be an interactive tool simply because you're inputting your agency information for the patient to call. Just as a filter example here, you can see that we go through the BPIP, left the BPIP just as is, selected self-management. For the patient, left language and material type. Material type, it nets us down to 120 options. If we select English, that narrows it down to 55. That's a more doable review. So I do encourage you to use the filters as you're working through here, because it can get very daunting if you just bring up all of the resources that are available. Now, the search feature on the campaign website, if you happen to know you're looking for a specific zone tool, you could just put that in there. But most of the tools you may not know the names of. That's the reason I wanted to show you both of these. Now let's go under education. The education link on the blue toolbar, you see we're still on the same main page. We were under resources, which is just to the right. Now we're under education, and this is where you're going to find the university. You'll also find all of the QAPI resources. No matter where you are in regards to your QAPI development, and I'm sure that you're pretty far along, but even if you're not, or maybe you have a new clinician showing interest in quality improvement, or maybe you have a new quality improvement person, or maybe this quality improvement person that you've just hired has a history of quality improvement in a different setting, such as a hospital or a hospice. This is QAPI for home health, and we all know that that's different from hospice and other care settings. So these resources have been created for you to use. It's based on the language from the COP, and the links for the COP are in there as well. QAPI 101 is a general overview. That gives the whole plan of what is required for a QAPI. There is a QAPI fact sheet that's very easy to read, but really wanting to get into QAPI 101, which is an educational course. Now, CEs are awarded for QAPI 101 for all of these, but even if you have someone who you want to read this that is not interested in the CEs, they still can take the courses so that they can learn about it. This is extremely, well, we had the feedback that it's been extremely helpful, especially when you have agency leadership that is not used to being a fairly active and engaged part or participant in the quality improvement process. COP mandates it, and that's what we want to have on this. So if that would be helpful to you, just know that it's available. Part of the QAPI development are the PIPs, the Performance Improvement Projects. We went ahead and created a PIP tool for hospitalization, med management, and cardiovascular health, which walks through the general information of what you're looking at, how to implement your data, how to create your evidence-based goals or expected outcome statements, and then you'll find a really great two-column, multi-page area where you can identify what your data is telling you as to where you need to focus, and then next to it in the next column are hyperlinks to different tools and resources that may meet the need for that specific problem. So let's say it's hospitalization and you found there's a specific day of the week that is an issue. In the column across from it will be the hyperlinks to different tools that may help you meet that need. What we try to do is to eliminate anywhere that we can the effort so that you can come in, get what you need, and get out so that you can keep doing what you're doing. That's what our job is to support in any way that we can. And finally, excuse me, QAPI Canvas. It's been made very clear to us that we are not to provide a template, any form of a template for QAPI at all. CMS wants the agencies, they want you to have the freedom to create whatever works best for your setting and for your patient population, and that's wonderful. But we had so many people have issues of where do I even start that we created QAPI Canvas, which is at the bottom of this page, that will allow you to get your mind around what it is that you need to do. It's a very simplistic way to just kind of get started and really more of a brainstorming tool. Now the university, whether you are a nurse, a therapist, a social worker, a home health aide, or maybe you're just interested in the content itself, HHQI University has, I should have counted, but probably over 50 to 60 courses. They are approved for different CEs per discipline. They are also open to everyone. So even if you are a therapist and you're wanting to take a course that is not approved for therapy, it doesn't matter. You're still going to get a certificate of attendance. For those of you that are quality improvement oriented, we've heard many who are already using these courses as part of their QAPI. So as you're finding a course that has the content that you want your clinicians to understand, you can assign the course. They can create their own university login and registration. They will turn into you their certificate of attendance. That tells you that that person has taken the course. Whether they want the CEs or not, it doesn't matter. They still get a certificate of attendance. We've had home health aides taking all of the courses. That's fine. Everybody's welcome to. But there are specific courses developed just for home health aides that address the issues in the COP. And as you're working with your community providers, keep this in mind as well. You may be working with some assisted living folks. You may be working with some nursing homes, and they're your upstream and or downstream providers. These are folks that may be interested in this content, even though it is home health focused, especially in the home health aid courses. That content translates across different care settings. So keep this in mind as you're working with them and you want to bring something to that community table. This might be something that you would want to share with them. Now, as I said, CEs are offered, and this is the reason that this is the second registration and login in HHQI. Because of the fact that CEs are dealing with a legal certification of licensures, we needed to have it under a different level of security. So for that reason, it is a different login, and I realize that it's not fun, but it's necessary. So think of these systems the same as you would maybe Walmart and Amazon. You may have two different logins for those. That's the same as for this. All right, so that's it for the university. And if you are interested in the CEs, your certificates are all kept in one place. You can download and print them, but they'll always be stored in this system itself as well. I got ahead of myself. I apologize for that. This is talking about the different registrations. And it is important to maintain only one username for this system. If not, it can cause confusion and your certificates may come out disjointed, and we don't want that for you. When you're looking at the university as far as the courses go, some of the courses may be to review the best practice intervention packages. Others may be to watch a video. They can be any number of different required activities, and most of them are 1 to 2 hours in length because of the fact in home health, we don't often have more than a half an hour to an hour to sit down and take a course. It is asynchronous, start and stop as often as you want. When you go into the My Account in the university, this is where you will find your certificates. Now, that's about it for education. Again, I'm giving a high-level overview of this. I just wanted to introduce you to the content. As we're moving through EDNA, EDNA, we'll move next to data access. HHQI creates individual reports for every CMS reporting home health agency. All 13,000 agencies have data sitting here waiting on you. Whether you want it or not, it's there. We create them every month. And the focus are on 4 individualized reports: acute care hospitalization, oral med management improvement, and both flu and pneumococcal immunization reports. All of the data source itself, is your OASIS. So if you transmit OASIS data on every single patient, that's what's going to show in these reports. If you only transmit it on certain payer sources, that's what's going to show in the report. These are for your agency, and these are raw data, meaning that it's not risk adjusted. There are 2 tables that do have risk adjustment to them, but that's 2 tables. The rest of the reports are raw. This is your third and final registration. There's also PHI found on this data access website, so for that reason, again, there's a different level of security that was required. You can find historical trends dating all the way back to 2009 for ACH, 2012 for oral med, and I believe it's 2015 for your immunization rates. Now, these reports are multi-pages in depth. Again, we were given this tremendous amount of freedom by CMS to create reports that we would have found helpful when we were in the agency. So you're going to get your actual rate, but then you're going to get any variable that we could pull from the OASIS and how it's influencing that particular rate, such as your, say, your ACH. We're going to look at the day of the week. We're going to look at your payment source, the age range of your patients, which age population is returning to the hospital more frequently. And on the final page of both the ACH and the oral med report is where you're going to find the 2 tables that have risk adjustments. Now, the risk adjustment rates, for those of you that are not data-oriented, don't worry, we won't hold that against you, but those are the rates where the data has been treated to allow you to see what your agency, how it compares to other agencies of same case mix and size from across the country. It removes that My patients are sicker, we're too small of an agency, we're too large of an agency. It removes that element from the discussion of looking at the data. But also what you'll find on there are comparison tables, percentile rankings of all 13,000 agencies. How does your agency rank with all 13,000 in the country? How does it rank with all 13,000 or however many in your state? So you're going to see what ranking you have in the nation and what ranking you have in the state. This is an important thing when you are developing your QAPIs. If you are using a hospitalization rate for a goal statement, I don't want to speak for you, but I know that you come from all parts of the country. I'm coming from West Virginia, and we have a terrible time with influenza season. And our patients, because of our elderly, conditioned patients and our terminal and chronic diseases, our patients go in the hospital more frequently in the influenza time period. Keeping that in mind, if I say that my goal is to have an ACH rate of, say, 19%, well, what month is that going to be? If you use the percentile tables, everybody's in the flu season, influenza season at the same time. And so if you use the percentile rankings as instead of an actual rate, that may give you a more concrete, fluent goal statement. That may sound a little convoluted, but it's just something to consider when you are developing your QAPIs and you're developing your goal statements. Saying that you're going to have an ACH rate of a certain number is really fantastic, as long as you know what month it is that you're looking at that, because you probably fluctuate depending on and there's other seasonal issues as well. Those of you that have snowbirds, those of you that lose your patients because they're snowbirding, whether you're the receiving or the giving end of the snowbird season, this is something to keep in mind as well. It does alter our population, our patient population in home health. As I mentioned, these are the reports that are covered. Now, the asterisks at the bottom, so the first four, ACH, oral med, flu, and pneumococcal, those are created and they're waiting on you. No problem at all. HHCDR, it warranted an asterisk. This is the location of where you will find the Home Health Cardiovascular Data Registry. This is the registry that is created for home health that is focusing on the aspirin, blood pressure, smoking, cholesterol, and cardiac rehab measures that align with physicians' offices and hospitals around the country and align also with the Million Hearts Initiative. This requires data input. It is a registry. Now, again, to be clear, the first four are individual reports that are there waiting on you, whether you've asked for them or not. The HHCDR will only be a report if you have actually inputted data. That's a very simple process. It was created simply so that it's really a glorified chart audit tool, but we wanted to, again, our goal is to try to simplify things as much as possible so that you can use your time doing more important things, and so that's the reason for the registry to be created. But this is the location of where you will find the HHCDR, and that is kind of a frequent question that we get in a roundabout way. People don't come to us with that question. They're asking CMS and other areas, where is this located? It's all located on HHQI. To get to this area, you will go to the website. Again, we're back to the general website, same place we've been multiple times already today. And you click on the word data, and this will take you into the data portal. This is what it looks like. And you will notice down here in the bottom is where you'll see register and login. That is your third and final registration. Now, because the fact is that this data is not open to the public, it is raw, it is specific for your agency, we create the reports and we house them, but they're your agency's property. For that reason, the way the system is set up is one person at your agency will be the administrator of this account. It doesn't have to be the administrator of your agency, just the administrator of the account. This will be the one person who has to go through an extra level of security checks, but once this person is approved, that person will approve and deny all others access. It's unlimited how many people at your agency can have access to this. Some agencies have 1, some agencies have 50. We don't care because it's not our property. But that person that you select to be the administrator at your agency, you want that person to be a little on the conscientious side and not just approve anyone. Anyone in the world can register to ask to access your data, but they're never getting near it unless you've approved them. So if the administrator of this account is someone who would just go in, yeah, and approve, that's probably not the person that you want. You want to make sure that you know who you're approving because they're going to have instant access to this data and to your PHI. In the upper right-hand corner is where you're going to see the step-by-step manuals and webinars, as it says there. It's an entire page of resources, as well as the data FAQs and the cardiovascular-related FAQs. This is what just a section of the resource page looks like. I just wanted to show it to you. You can find actual manuals of the oral med and the ACH, of all of the reports. You'll also find report samples. So before you go through the trouble, you may want to just have a look at these reports to see if it's something that you're interested in. I will tell you, no matter how wonderful of a vendor you have, or no matter how wonderful of a system that you have, and there are some great systems and vendors out there, the HHQI data is what CMS has received from your agency. Your vendor reports, as great as they are, and especially when they're in real time, but those are telling you what has been transmitted to CMS. Now, it seems like it should be a smooth process, and if there's 13,000 agencies, it's probably an extremely smooth process. But we hear from the 2 or 3 per month who didn't have it so smooth. They'll look at their HHQI report, and the call I get, and I get this, like I said, a couple times a month, you don't have our data in your reports. Well, we immediately stop everything because human hands do touch our reports at one point in our process. We pull it, we look, and so far, touch wood, in 10 years, it hasn't been on our end, but it is something that we stop and look. Then we work with the agency to figure this out. And I've heard across the board, either the vendor didn't check something that didn't get transmitted, or CMS didn't check something to where they received it. Or sometimes if you are not using a vendor and you're transmitting it independently, sometimes people have intentionally not transmitted, and therefore there is an opening at that agency for a new job. Or sometimes they have transmitted and they thought they were doing everything right, but something didn't go correctly. It doesn't matter why. But if your data is not getting to CMS, that's going to put you on a fast track to an unexpected survey. So you want to make sure that your data is at least being received and is similar to what you're expecting. So I encourage all agencies to at least eyeball these data reports. It's just once a month. They're PDFs. They don't change. They're not real time. They're about 6 weeks old, the data is, but at least eyeball it. This is a way that you can preemptively stop a problem that you didn't even know existed, and this has happened. It's heartbreaking, but it has happened many times. So, okay, enough about that. I apologize for going on, but that's one of my least favorite calls that I get because I know this agency is going to be in trouble, especially when they haven't looked at it for 6 to 9 months. CMS hasn't received their data for a number of months. That's a problem. And I don't want that for any of you. So navigating data access, once you get into here, everything is on. You'll notice this is a tan toolbar. It does look similar to the general access that we were talking about earlier with the blue toolbar, but you'll notice this is just a little tan. When you get into this aspect of it, you can navigate any way you want. The second link is going to take you back to the main campaign page. You will notice the HHCDR halfway across on the toolbar. That is going to take you into the registry itself, and you'll also see the resources. That is another link to go back to what we just talked about. In the middle of the page, you'll see the HHCDR where it has the where you can get your reports. When you open that page up with the down arrow, it'll have all of your reports listed. So if you're going in there today and you've never entered data into the registry, there's no reason to even look at your HHCDR. It's not going to be existent. But if you open that up, you'll notice that there are multiple, I'll show you on this one. You'll see the ACH report, oral meds, and your flu and pneumococcal reports. You can click on those and open them up, and you'll have access to your data. This is a sample of what the reports actually look like. And you'll notice there's different graphs that go along with them. In many cases, if there is a specific area that you wish to focus for your agency, and you don't want to share the data itself, which is understandable if you choose not to, but you may find that the graphic is something, it gives you a visual that you can put somewhere, maybe on I don't know if you're using a time clock or the front door or the back of the bathroom door, or the kitchen in the on the refrigerator, just somewhere that it keeps the eye on the ball of what is the topic, what is the outcome, what is the focus that you want the agency, you and your agency are focusing on this month or this quarter. And this is a little bit about the registry, as I was mentioning. It does cover the ABCS, and it aligns with the Million Hearts Initiative. We're looking at very simplistic aspirin. All of your patients that have ischemic vascular disease, that's your patients who have had, most of your patients that have had heart attacks, strokes, any type of arterial disorder where the oxygenated blood is not reaching the tissue. That could be your peripheral artery disease. That could be your Raynaud's disease, your cold agglutins, as well as, of course, like I said, most thrombotic CVAs, strokes, and most heart attacks and angina. Are those patients taking aspirin or another antithrombotic? Yes or no? Blood pressure? Your patients with hypertension. How many of them were discharged with a controlled blood pressure? And I will tell you, this is for the patients with hypertension that do not have renal or pregnancy issues. And for that population, a controlled pressure, according to the most recent standards, is 140/90. Cholesterol, for your cardiovascular patients, were they taking a statin, yes or no? Cardiac rehab, during the episode of care, did the patient receive a referral to cardiac rehab? And remember, the episode of care includes the day of discharge. And smoking. How many of your patients were screened for tobacco use? And if they were found to be a tobacco user, how many of them received any type of cessation counseling or pharmacotherapy? Now, when we talk counseling, we're talking about 3 minutes. These measures are created for physicians' offices and hospitals. They're not created for home health. We have adapted these are the measures that your community providers, the physicians and hospitals, are monetarily incentivized. Either they are receiving penalties if not enough of their patients are meeting these measures, or they are receiving awards for their patients meeting them. Either way, home health is not held to that standard, which is excellent. Granted, we could use extra money, but we're also not forced into it. But I wanted to mention this. This aligns with what your upstream and downstream referral sources are already doing. So if this is an area, if you have a high cardiovascular population, this is an area you may wish to focus. The good thing on this is that you can pick which of these ABCSs you wish to focus each month. It doesn't have to be the same. You can do any one or all 5. You can do anything you want. Again, total autonomy. The ball is in your court if this would impact your patient outcomes. If you don't have a high cardiovascular population, then maybe aspirin and cholesterol cardiac rehab might not be as impactful. But if you have wounds or respiratory patients, if you have a high population of those disease management issues, you know that tobacco influences way more than cardiac. And so if you have a wound, I'm sure you're already incorporating tobacco use as part of your wound program, that this would give you actual data to support your efforts and keep it with data-driven quality improvement. Same with respiratory. Whether it's pneumonia, COPD, it does not matter. Maybe you have a high asthma population, whatever the respiratory situation is, if you have implemented that disease management program, you probably are already addressing smoking cessation. You can use this registry to collect the data for that and have this nice report in your hand, and you don't have to do the effort other than input a little bit of data. And I'm talking very little bit of data on that one. Now, the registry, as I mentioned, this is where you will get the report, and this is where you actually enter into the registry. And the report you'll receive looks something like this. I did not highlight this. This is the way your report looks. And it will show you your agency compliance on each of, I just picked blood pressure just because it was here. Now, the very bottom row says total data registry measure compliance. The reason that doesn't say national rate is because 2 reasons. Not everyone in the nation is doing this, so we can't call it national. The other reason is because that number will change. You can go back up to 6 months and enter data, and will alter that number for all the agencies in the country. So that's the reason for that long title there. Just a few more details about the registry itself. As I mentioned, you will select which of these areas of topics that you're interested in focusing, and you can do all of them or one of them and alter it around. For simplicity purposes, I will tell you aspirin and cholesterol and blood pressure are probably the easiest ones simply because everybody has a med sheet. You can look to see if they're taking aspirin. You can look to see if they're on a statin. And blood pressure, you're looking for the last blood pressure from the time that the patient was under your care. Really simple. And the registry is pre-populated with your patient demographic information so that you don't have to enter that. We get that from your OASIS, and this is where I was mentioning there is PHI. That's the reason for the level of security and the third login registration. It's pre-populated. You will be, as soon as you select one, you'll have no more than 12 episodes per topic area that you've selected that are there available to abstract. Once you complete those 12, then you'll be given the opportunity to abstract as many as you want. We do the random selection of the first 12 to remove that hunting and pecking type of selection process. And even if we don't intentionally pick and choose which patients we're going to abstract, anybody that's done chart audits, you know how it is. Oh my goodness, this patient, this is going to be the worst patient in the world. This patient didn't do anything we asked them to do. You know you have a few of those patients, and you don't really want them because they're not representative of your agency. But in order to add validity to this report for your agency, we needed to do this. Now, you don't have to complete. If you open this up and you do one patient, or you can do none. Again, you have the control of how many you do and what you do with them. And the underserved population, we talked about this briefly. This is a very strong population that I'm sure every one of you, if you're not already, you will be addressing simply because this is a group that can tend to alter our outcome rates because they respond differently to the information and the interactions that we have. Whether it has to do with health literacy, whether it has to do with language spoken, language read, it doesn't matter. We try to address all of that. So many of the tools, as it says here, I'm just going to read it, many of the tools are health literate and translate. Most of the tools are health literate. We've had a conscious effort on that for the past 7 years now. Many tools are already translated. You can have a look at those through the library, as I mentioned. The underserved population is one of our 2 groups that we have actual learning action networks that called LANs that meet quarterly and discuss topics. We bring in presenters for experts on different topics that impact this. If any of you are already participating, you probably heard one of the best presentations on caregivers just a couple of days ago by Warren Hebert out of Louisiana. And it was a phenomenal webinar. But all of these are recorded, and they're kept on the website, and you can go back through them. There's one that I still go back to frequently, and it's probably 8 years old. It's on hoarding. Hoarding is a situation that we in home health, I think that we're a little unique in the sense that we have to deal with it. And it is a definite obstacle to our patient outcomes. So these are different topics across the spectrum, and they're all available to you as well. And if you'd like, we do a quarterly, monthly update newsletter that has specific topics and resources for this particular population. Now, the second group that we have is the Cardio LAN, and this is a group focusing on, because those ABCS measures, that's a level of prevention that we in home health hadn't really had a focus on before. If we talked about cardiovascular prevention before this, we probably would have been looking at preventing heart failure exacerbations or catching them before they bought an ICU bed for 5 to 10 days, and maybe hopefully they just needed a little one-day overnight hospitalization OBS bed for tweaking. That's our goal now. But taking this level of prevention to a higher level of preventing that heart failure from occurring in the first place was a new concept for all of us in home health. So for that reason, we created the Cardio LAN, and it allows for networking of like-minded agencies who are focusing on the ABCS measures. Again, it meets quarterly, has a different guest experts that come in and discuss different areas focusing on the cardiovascular and the application of how to actually do these interventions. And you're hearing from actual clinicians and quality improvement experts of what they have found to be a best practice for them. And of course, Both of these lands give you direct access to the HHQI team. And it doesn't matter if you personally are not one to be on Facebook or Twitter or maybe Pinterest, but these are areas that your clinicians probably are. Sharing with them additional resources besides maybe how the Kardashians are doing and whatever else we're going to find on Twitter. Just sharing with them that HHQI, we do submit different home health related evidence-based topics and resources through these platforms as well that it might be worth sharing with your staff. That way they can keep the focus in addition to social media can be a little bit more useful. There are multiple mailing lists, and we're very conscientious of your emails because of the fact is that we get slammed with a lot of emails too, and we don't like it any more than you do. So once it's very strict, you control which mailing list you're on, if you want to be on any at all, so that you're not getting things that are not of interest to you. So there are different mailing lists that you can subscribe to. And finally, in our Edna, we're down to assistance. And with assistance, there are multiple places on the website that are help, contact us. That all comes into our main mailbox of hhqi@qualityinsights.org. You can just email us any question you have. We encourage you, no, I'll demand that you do not send your reports. We have access to your reports, so if you want to discuss your data or you want to discuss this, I don't even know where to start. Or it might be, I can't remember my username or password. It doesn't matter what your question is. If we don't have the answer, we're going to look for it for you and try to find additional resources. Even if the resources aren't available on HHQI, we're going to look for them and see what we can do to help you with that. So, Anna Marie, if it's okay, I'll just stop for questions and then see if there's anything I can help with.
Thank you so much, Cindy, for a delightful and extremely enlightening presentation. Everyone, if you have questions, feel free to type them in the chat window. Also, we'll make sure that you have HHQI's contact information to follow up accordingly if there's something specific after you review the webinar recording. This was an extremely insightful presentation. I think everyone learned a lot about the extremely valuable resources and tools which can benefit their agencies in their care delivery. And thank you everyone for listening to the webinar. We will make the recording available to everyone by the end of this week. Today's webinar was hosted by Cindy. Our award-winning platform allows home health agencies and post-acute care organizations to engage patients and colleagues via video, email, SMS, and text, obviously all HIPAA compliant. Our platform is accessible on any smartphone, tablet, or a computer. So typically these are the devices that your agency, your staff members, and your patients and caregivers already own and already use, as we all know, probably 24 hours, 7 days a week. And it's also available on any level of cellular or Wi-Fi connectivity. We're dedicated to providing better ways for you to manage and engage patients simply and efficiently, and we look forward to the opportunity to demo our platform with you and discuss how it can help your organization provide value-driven and patient-centric care. Please visit cinzy.com for more information. This concludes our presentation today. Thank you again for everyone's time and interest, and a special thank you to Cindy and HHQI for bringing all of this informative tools and resources to our attention. Take care.
Thank you very much. Have a good day.